If you work as a nurse in the NICU, UACs and UVCs, also known as umbilical arterial or umbilical venous catheters, are types of access that you will use almost every single day. So it's important to know what they are, what proper placement is, what we can use them for, and how to recognize complications and troubleshoot. If this is your first time seeing one of my videos, I'm Liliana. I've been a NICU nurse for about 3 years, and I love to make videos about different disease processes and equipment you might use in the NICU. Today we'll be talking all things umbilical catheters, both umbilical venous and umbilical arterial catheters. So definitely subscribe if you want to see more of my content, and I'll put timestamps in the description so that you can skip ahead to parts of the video that you think will be helpful to you. So first of all, what are umbilical catheters? First, we need to understand the makeup of an umbilical cord. Every umbilical cord should have 2 arteries and 1 vein. Sometimes a baby will be born with an umbilical cord that just has 1 artery and 1 vein. This is typically associated with some kind of genetic anomaly. The way I like to remember that there are 2 arteries and 1 vein is the acronym AVA, artery, vein, artery. These vessels go back to the placenta where exchange of blood flow happens in order for baby to receive oxygenation and then take deoxygenated blood back to be oxygenated and also waste products back to the placenta. And remember, artery means away. So the umbilical arteries are actually going from the fetus back to the placenta, and the umbilical vein is the one carrying oxygen-rich blood from the placenta to the fetus. I know we usually think of arteries as having the oxygen-rich blood because that's how circulation works in our bodies. Just always remember that artery means away. So in fetal circulation, it's just carrying the deoxygenated blood away to get reoxygenated by the placenta, because the oxygenation isn't happening within the baby's body, it's happening in the placenta. These vessels are surrounded in the umbilical cord by what's called Wharton's jelly, which is that sticky gelatinous part of the umbilical cord that you see. So when a baby is born, the provider delivering the baby will usually place an umbilical clamp on the umbilical cord and then cut above it to disconnect mom and baby. The clamp that we put on there helps the umbilical cord from bleeding out. If that clamp isn't on there, the baby could have some blood spurting out of the cord. So that's why the clamp is there. The clamp is typically left on for 24 to 48 hours after the baby is delivered or until it's dried out. At that point, the clamp can be removed, but the little stump of the baby's umbilical cord will stay there until it falls off, which could be anywhere from a week to a couple of weeks. So umbilical catheters that we're gonna be talking about actually go into the vessels of the vein and the artery. But if you've never seen one in the NICU, you're probably wondering how we get the catheter into those vessels. What they will do is when we get a baby coming to NICU that will need an umbilical line, they will already have that clamp on. And what the provider inserting the lines will do is they will take a tie and wrap it super tight around the stump of the umbilical cord, and they will actually cut below the clamp. Let's say you have the stump and the clamp. The provider will tie super tight around here and take a sterile cutting device and cut below the level of the clamp. The baby won't be bleeding out because it has that tight tie around it, but that gives them access to the openings of the artery and the vein. From here, they will attempt to thread a catheter. I've usually seen 3.5 or 5 Frenches, depending on the size of the baby, into the vein and or the artery until it sits in optimal position close to the baby's heart. For the positioning of an umbilical venous catheter, we want it to sit at or around T7 above the level of the diaphragm. The way I like to remember this is T7 is heaven. And the path that the catheter will take to sit in the central position is it will go through the umbilicus into the umbilical vein, go through the left portal vein and through the patent ductus venosus, thread through the middle or left hepatic vein until it sits in the inferior vena cava. This is ideal central placement for a UVC. You may also see a low-lying UVC every once in a while. Low-lying UVCs are ones inserted just a couple of centimeters into the umbilical vein and are typically used in emergency situations, like when a baby is coding and we need extremely quick access. But they are not meant to be left in long term. They are not central. So again, that ideal positioning is going to be T7. Every once in a while, a UVC can end up in the liver. And why that can happen is because of that patent ductus venosus I mentioned that the UVC travels through earlier. The patent ductus venosus is a part of fetal circulation that helps the baby bypass the lungs. It's a very complicated blood flow pathway, but that patent ductus venosus is essential for fetuses. A lot of times these lines are being placed immediately after birth, and so that opening should still be patent. for the catheter to thread through. However, if the patent ductus venosus is no longer there, it's closed up, or if the catheter just won't go through the patent ductus venosus, it wants to go into another part of circulation, you can end up with the catheter threading into portal circulation in the liver, which is never a good thing and can end in a bunch of complications for your baby. Which is why at every NICU I've worked at, they always require an x-ray to be taken before starting fluids through a UVC, to be extra sure that we are not in the liver and to avoid any of those complications happening. On the other hand, the UAC will take a bit of a different pathway to sit in its optimal position. A UAC will start in the umbilical artery, go down into the internal iliac artery, then into the common iliac artery before it starts to make the upturn and it'll sit in the aorta. Ideal positioning for this line is anywhere from T6 to T9. And the way I remember this is T6 to T9, you're doing fine. The difference in insertion depths between a UVC and a UAC will usually be pretty different. There is a formula that providers use to calculate approximately where a UVC and a UAC will be based on weight for the baby. I'll put it on the screen. That's something usually providers handle, but just so you're aware of how they're calculating it. And the reason why a UAC typically sits much deeper than a UVC is because of that downturn it has to take into the iliac artery, where the UVC doesn't have to take that downturn, if that makes sense. So you might have a UVC at 6, but a UAC needing to be at 13 or even more. And that's pretty normal. Based on your hospital's policy, your providers will follow x-rays based on their policies for following where these lines are, so that we can make sure that they're staying in a good spot for the duration of the time that the baby has the line. One thing that I may have forgot to mention is that these lines need to be placed while the umbilical cord is still fresh. It really needs to be done when that baby is fresh before that Wharton's jelly starts to dry out. So this isn't something we would obviously be able to do on a baby that is 2 months old and already has a healed belly button. So now that we kind of know the basics of UACs, UVCs, where they sit, the path they take, let's talk about UVCs and everything you need to know about them. So UVCs, it's an umbilical venous catheter, right? So it is sitting in a big vein. We typically like to use UVCs for the bulk of nutrition, any drips or continuous medications the baby needs, especially vasoactive medications, because those can obviously not go through an artery. We also just prefer them in general for bolus medications to avoid putting things through an artery. UVCs can be single or double lumen, depending on what your hospital has, what your provider is able to get in the baby, and what the provider is anticipating the need for the line being. If this baby is very sick, they will usually prefer a double lumen because it gives us more options for access, versus if a baby is just born like a little bit small and we're anticipating them needing some fluids to bridge the gap between feeds, a single lumen might be appropriate. That's a provider decision, but just so you know what they're kind of looking at. If you do have a double lumen, some hospitals have policy that you have to run at least a KVO fluid through each lumen. Other hospitals, you may be able to use a heparin flush and hep lock one of the lumens. Use it for blood transfusions to avoid IV sticks. But again, every hospital is going to be a little bit different. And why these lines usually need to have heparin containing fluids, at least at a KVO rate or a heparin lock, because these catheters are very small. Like I said, there's usually a 3.5 or 5 French. And there's a high risk of thrombi and occlusions, even more so when there's not something constantly pushing through the catheter. So never just completely turn off fluids, have nothing going through them without an explicit provider order. And if you're currently working in the NICU, you may have had a situation where the first 24 hours the UVC looked great on x-ray, they get a follow-up x-ray in the morning, and all of a sudden the UVC is too high and the providers are asking you to pull it back. When you look at the baby's umbilical stump, it's still at the same place that it was yesterday. So what happened? Sometimes the drying out of the umbilical stump can lead to the catheter kind of becoming malpositioned and going in a little further. A lot of times after we've stabilized the baby, they may also have better lung expansion, which can affect the catheter placement, or they may have more gas in their belly, which can also affect where the catheter is. So that's why it's important that your providers are following x-ray, letting you know if you need to adjust the catheter, and that you're always keeping an eye on where your catheter is at the stump, documenting it in your EMR. And a lot of times these lines will be sutured into place. So when you go to remove it, you never ever want to use scissors near these lines. You don't want to risk accidentally cutting one of these lines. And if you're ever feeling any major resistance when pulling back on a UVC, either to adjust the placement or remove it, I want you to call a provider immediately. You should never have to tug on it to get it to come out. That could result in the line snapping, which can have major complications for your baby. So just use your judgment, follow your hospital's policy, and understand that that might be why you are being asked to adjust the catheter. Now, UVCs are not lines we can leave in forever. Although that would be super convenient for us, they are a central line and meant more as a temporary solution, as a bridge to baby either not needing fluids, getting a PIV for a couple of days, or getting a PICC line, which is a more long-term stable form of central access. Typical lifespan of a UVC is around 5 to 7 days. If a baby is extremely critical, I have seen them in longer, but it's part of our job as nurses to advocate for timely removal of them. Some of the complications we see for umbilical lines, like I mentioned, are occlusions or thrombi. So if you are starting to have any pressure increasing alarms or occlusion alarms on your pumps, you want to let your provider know right away so that they can come troubleshoot the line for you. That is most of what I can think of that you would need to know for UVCs, so let's move on to UACs. UACs sit in the umbilical artery, umbilical arterial catheters. These are typically single lumen catheters. I personally have never seen a double lumen UAC be placed. The main purpose for this line is going to be blood pressure monitoring and lab draws. We can use them for nutrition or even medications depending on your hospital's policy if we absolutely have no other access. But ideally, this UAC is going to be run at a KVO rate, and the benefit of it is being able to monitor continuous blood pressures and draw labs off of the line. To monitor blood pressures, your tubing will have something called a transducer in it. This transducer will connect to a part of your monitor. The transducer should sit around the level of baby's heart in the bed. You will have to zero this transducer, make sure that it stays in a good position, that it's reading effectively, to be able to watch your baby's continuous blood pressure. I have made a TikTok before about how to troubleshoot when your UAC is not reading great, because sometimes that can happen. It's not every time that you get a UAC and all of a sudden you get a perfect waveform with an accurate blood pressure. But to quickly summarize, some of the things that may help would be increasing the KVO rate. Sometimes the catheter can get stuck up against the wall of a vessel. So if this is your artery, the catheter is kind of sitting like this. When you increase the KVO rate, say from 1 to 1.5, it kind of opens the artery up so that the catheter sits more in the middle. Obviously, that's a discussion with your provider. A lot of things can impact a KVO rate, like the baby's fluid status, total fluid goals, but it's something you can advocate for if you feel like that might be the case. You can also zero your line, adjust the transducer. Things like that may help it read a little bit better. Just like a UVC, a UAC does need to have a KVO fluid running through it at all times. It also usually needs to have heparin. At the hospitals I've worked at, I typically see providers order things like heparin sodium, heparin with sodium acetate, things like that at a KVO rate of 1 to keep the catheter patent. Because again, it's a really small catheter. It's usually a 3.5 or a 5 French single lumen. Your UAC tubing will typically also have some kind of stopcock draw system for you to be able to draw your labs off of. So you will have to draw a waste, your sample, and then have a flush. In the NICU, because our babies are so small and every precious drop of blood matters, you will usually always give your waste back to the baby. I don't want to say too much about how to draw from a UAC because every hospital setup is going to be a little bit different. The main thing I want to iterate to you is that you want to draw super slowly, especially if your baby is extremely premature. As slow as you think you should go even slower. When we're talking about drawing even 1 to 2 mLs of blood from these patients, or doing a 1 to 2 ml flush, that can be a lot of volume depending on their weight. Just simply drawing from this line can cause big pressure shifts within them. We want to make sure we are really protecting baby as much as we can and going super slow with our draws. And with UACs, the main complications are going to be vasospasms and thrombi. Blood clots can form on the catheter and break off, or there can be an obstruction of blood flow from vasospasm, which can ultimately lead to compromised blood flow, particularly in the lower extremities. So if you take anything from this video, it is to keep an eye on your baby's lower extremities, their little tips of their toes when they have a UAC in place. You never want to swaddle them all up or cover their legs with a blanket. You want to be able to see it at all times. Those little tips of their toes may start turning purple or black even. So if you see any new duskiness, bluish, purple hint to your toes, you want to let your provider know immediately. This may also manifest as some duskiness on the buttocks. Making sure that you're doing a thorough assessment of the baby's back every time you do a care time. Also checking lower extremity pulses and cap refill is going to help you out here. Sometimes if it is just one lower extremity that is affected, let's say you are just noticing some discoloration on your baby's left foot, the provider will usually have you put a heel warmer on the opposite foot or opposite side of the groin. And you might be thinking, why would I put a warmer on the opposite foot? we want the blood flow improved in the other one. Actually putting it on the opposite side of the groin or foot can simulate a reflex vasodilation. Heating the unaffected foot can actually cause vasodilation in the opposite foot, which is going to improve blood flow. I was super fascinated when I found that out. It made no sense to me at first until I asked a provider and they explained that whole thing to me. So I hope that pops into your mind the next time you notice a little bit of duskiness in your baby's toes. You can advocate for that for your patients. And similarly to a UVC, this line unfortunately cannot be left in forever. The lifespan is also usually right around that 7-day mark, although sometimes I've seen UVCs left in a little bit longer, particularly in an unstable patient. Usually after that 7-day critical period, baby's a lot more stable. We're not having to monitor their blood pressures continuously. Hopefully those have stabilized. We're not having to get as frequent lab draws on them. So a lot of times the line can be removed without needing to replace it with another arterial line. However, if this baby is extremely unstable, it's creeping up past that 10-day-old mark, you're gonna wanna advocate for your baby to get something like a PAL, a peripheral arterial line, so that we can go ahead and remove that UAC. And let's cover a couple miscellaneous things that apply to both lines. A lot of hospitals have policies that parents cannot hold or do skin to skin with umbilical lines in place. Some hospitals have policies that you can do it with a UVC, but not a UAC. So just check your hospital policy, make sure you're familiar with it, and know that that might be a restriction for holding. Not in every hospital, but some. We want to make sure that we're securing our lines appropriately according to our hospital's policy. So like I said, a lot of these lines will likely be sutured in, which helps them from just coming straight out. But we still want to secure them to baby's abdomen in some way. Whether that's using Tegaderm, steri strips, all depending on your hospital's policy, but make sure that your dressing is secure. Ideally taping the catheter with numbers facing out so that we can easily count and identify where the catheter is sitting at the stump. That is going to help you and other nurses out a lot. Lastly, if these lines are in ideal position, these are central lines, meaning they are sitting close to baby's heart. These lines are usually put in sterilely, and we will need to make sure we're maintaining sterile technique when accessing the line, doing a tubing change, changing fluid, things like that. We want to make sure that we're being sterile. Again, be familiar with your hospital's policy for when to be sterile, when it's okay to just wear sterile gloves, when you need to have hat and mask. Just know that it's really important to prevent infection in these lines. So making sure that we're treating these lines with the respect that they deserve. And I think that's everything I can think of right now for UACs and UVCs in the NICU. I hope you learned something new, whether you've been working with UACs and UVCs for a while, or if this is your first time hearing about them and you want to learn more about NICU. Hope this video was able to help you out. Definitely comment below if you like this video or if you have any questions. My YouTube I use primarily for deep dives into NICU topics, but I am active on both TikTok and Instagram at lils.nurse_ for more lifestyle content and also shorter educational content. Definitely give me a follow on those if you haven't already. And thank you guys so much for watching. I'll see you next time.